you are in a level of misery and you're just like, I actually had a breakdown for a shower. Like, I would take showers multiple times, actually. That really helped me. Having the hot water helped calm me. So I think I went in like 3 or 4 times just to, like, it helped with the drainage because you can't blow your nose. It was mentally calming. And I you look at yourself in the mirror and you're like, what the fuck what did I just do to myself? And is it worth it? So I tried not to look in the mirror. So don't look in the mirror if you can help it.
Great tip.
However, when you're syringe feeding yourself, you kind of have to look in the mirror because I couldn't feel my face. So I had no idea where the syringe tip was. It was a little wild. I might laugh, but you kind of need a bib because you're drooling. So I basically had a towel on me even on my flight home, I was drooling. I just couldn't still feel my lips because they were numb. Be prepared. Have a bird bib for the flight if you're flying home.
Okay, Dr. Kim Santiago is back for a second podcast with me. And in keeping with the theme of this channel for this year, we're trying to get to the heart of what is jaw surgery really like. And Kim offers us a very unique perspective on that because not only is Dr. Santiago a dentist, but she also had jaw surgery. So she can offer a unique point of view from both sides of the scalpel or maybe both sides of the piezo knife, perhaps, would be more appropriate.
Yes.
So before we dive in, though, Doctor, I just want to say for anyone who is interested in what Dr. Santiago talks about in this interview and maybe wants to connect with her more, she is also going to be joining us inside of the Joint, which is my new membership space where people who are interested in going through their own expansion or having their own jaw surgery or just looking for answers on their airway health and what next steps might be in their own journey. The Joint is a membership space that I've opened up where I can offer myself and my availability on a regular basis to those people. And part of that membership is private Q&As with doctors like you. So if you're interested, then definitely check out the Joint and you can meet Dr. Santiago yourself in there and ask her questions. Let's dive in, Dr. Santiago. I want to ask you, take yourself back to the moment that you woke up in Houston, Texas. You realized the surgery is over. I'm awake now. I'm swollen. I'm bandaged. What was that like?
Such a good question. The first thing I noticed, and I think I might have said this on the last podcast, but it was like my tongue could barely reach my teeth. It was there, obviously, but I felt this weird sensation of my tongue not being cramped anymore. So that, I know that's not emotional at all, but it was just it was the weirdest thing. And you're kind of loopy and not fully aware of everything. But no, I was in a bit of discomfort as expected and extremely numb. So my surgeon used Exparil, which is a very, very long acting bupivacaine. I believe it lasts for 5 days. So I had, it was numb. I mean, so numb that I could hardly swallow. It was challenging. And I only could really find my lips and my tongue. I could only syringe feed myself really for the first week or two. So it was not unbearable, but I've had 3 children. So I know
you've had worse pain.
I've had, yes. So, overall I didn't, I had trouble swallowing. So I didn't actually take most of my medications. Do not tell anybody I didn't take my antibiotics, but I couldn't swallow. So for anyone who is considering, please ask for liquid medications, not pills. That way you can at least syringe. You can syringe it in. But it was really challenging. The pain for me was like meh. But the swallowing and then staying hydrated was a challenge because I couldn't swallow very well. So, but I came up with I basically ordered, you have these IV people, that nurses mostly, that will come to your home or wherever you are and do IVs. So that's what I did to stay hydrated. Was I had a nurse come to my hotel room.
And you struggled to stay hydrated because you literally couldn't open your mouth and take a sip of water because the site was just in so much trauma?
It wasn't trauma. It was the numbness. So I had no proprioception. Mm-hmm. And I don't know if partly it was mental. It wasn't pain. I couldn't open, obviously very much, but I'm a bad patient as well. So maybe it's my own problem. But I think, having, and I advise my patients that are going for surgery to consider having, like an Amazon delivery. If you're traveling somewhere, have an Amazon delivery with syringes and ice packs, because you want to ice pretty much all the time. That was the only thing that was really helping me, was wearing the little like a chin strap that has room for ice packs. So I had a freezer full of those. And I think I said this last time too. I really want to make a cheat sheet for what do you put in your hotel room, or what do you have at home? What do you do after? Same for before, even there's.
And what would that cheat sheet show?
Kind of like what I was just describing. So the things to have for immediately after. So requesting liquid medications. If you're traveling, or even if you're at home, considering having IV infusions for hydration. The things that I felt were easiest to swallow. Smoothies were okay. And this is right in the immediate few days right after. But miso soup minus the bone broth were probably the best because it had the most nutrition.
Did you have an appetite after surgery?
Actually, not really. A little bit. I would say maybe a little bit. Although, sorry, everybody knows that I'm a little silly that interacts with me. But my boyfriend was there taking care of me, and he was doing DoorDash, so it smelled really good. So, but I knew I had to consume some calories and get some stuff in. So,
so you weren't necessarily craving food, but you ate because you wanted to provide your body with nutrients. You ate out of a sense of duty, not out of a sense of desire.
Correct.
When do you think your sense of desire to really lay into a meal came back after surgery?
Because it's hard, you're very limited. You can't chew. At least I wasn't wired shut. I don't know how many surgeons still do that, but you're on a strictly soft diet. I'm not allowed to chew. And so, when the fatigue, I didn't want to be on a smoothie diet. So I did a lot of, Indian food because it's really mushy, mm-hmm. and cottage cheese and, just anything mushy, really, anything that you can use your tongue to substitute for, chewing.
Indian food is such a great idea, because I feel like even if you wanted meat, I know Indian food tends to lean vegetarian, but even if you wanted meat, the entrees from an Indian restaurant, the meat entrees, the meat is almost sort of shredded up, mm-hmm. and sort of mixed in with the sauce.
Yep. And the cheese that they put in it's that very mushy. So it's really easy to mush it. And I know I've had patients that have blended meat so they could have meat, but it's just I don't know. I think food should stay food.
Yeah, I don't like the idea of taking a burger and blending it or something.
Yeah. But it was nice. So the flavor, I could have different flavors. And
what about the spice, though, in how that interacts with the wounds?
No, my wound healed. So I probably didn't have Indian food for at least a month. I really did stick to broth, and the true liquidy things, and smoothie type things. But I didn't really have an appetite for probably the first week or two. And it was just for sustenance. And then because it was very fatiguing, even with just not chewing, it was very fatiguing, and it took me a long time to eat each meal. I would just give up after a little while. And then your appetite kind of shrinks, as you know, when you don't eat as much. So, I don't think my true craving for anything came back to I could chew, because it was more out of, I don't know. There was only so much variety, and then you're just doing it to you have to get some food in. So,
Yeah.
but I love salami. I have this problem with salami. Actually, that was my first food. My grandmother took a piece of salami and stuck it in whiskey, and I didn't really eat it as a baby, but I've been a salami lover. It's bizarre. Anyways.
Salami and scotch. Interesting.
It was because I think I was colicky. I don't know, but my parents don't. Go figure.
Or teething, maybe.
Yes. So, but I often have salami for breakfast. My staff think I'm weird, but, so I did crave salami. So, but you can still taste it. You just can't chew it.
So how would you get it down the gullet?
Oh, I didn't. I just kind of like sucked on it like I was a sucker in a way. And then I know that sounds disgusting, everybody, but
no, I have an 18-month-old. I get it. Trust me.
Or even actually like a tater tot. I actually opened the tater tot and like scooped out the middle of, like, so I could have that. That was like the only two weird things I did, but that I can remember at the moment. But
now you mentioned you didn't take your antibiotics. I won't press too much into that because that's, I know, kind of risky terrain to go down in terms of speaking about it and suggesting it. But
yes,
it is something that alt health people will consider. Another thing they'll consider when they do a surgery, besides skipping the antibiotics, is fasting, which is why I sort of asked about if you even had an appetite. One thing I've thought about for myself after a double jaw surgery would be like a more extended fast of maybe 7 or 10 days. Did you consider that for autophagy purposes? Or did you even tell yourself, hey, I'm not going to eat until I really have an appetite again? Or did that not cross your mind?
It didn't even cross my mind. And I don't know for the autophagy piece, which I think is fascinating and we all need to be considering and doing that. I don't know if it would impact healing, that initial healing phase or not.
Like negatively impact it?
Yeah, positive, negative, I don't know. But yeah, I didn't really consider it. I didn't have a good full plan, and that's why I think it's great to have a conversation like this to help really put ideas out there. Curious what the surgeons would say about.
Yeah, and I'm curious as well about whether fasting with a surgery that requires so much reconstructive resources by the body, because obviously, like if you have the flu or if you have cancer or something and you want to fast so that your body attacks whatever the illness that's existing, starving the cancer or preserving resources so that pathogens can be fought off by the immune system, that's one thing. But tearing up tissue and then needing your body to rebuild that tissue, maybe fasting is not appropriate for that. I don't know, honestly.
Or do the fast before so that you're optimizing your immune system. And I think that in my mind, that would probably be that would make sense. But I guess when you're doing a fast, you're still drinking water. So you're still keeping hydrated. So
yeah, generally like an electrolyte drink, like salted water or something.
Yeah.
Or I'm not even going to say it, but have you heard of urine fasting? It's a thing. There's a famous book from the 1940s called The Water of Life, where this guy, John Armstrong, would cure all of these intractable patients with extended urine fasts of weeks or even months in some cases. Yeah, it's worth a read. It's a free PDF that you can get online, but fasting is an interesting topic. While we're on the subject of recovery, was there anything else that you would add to that cheat sheet for the hotel room?
Yeah, let me see. So the ice, let me see, the hydration, you might laugh, but you kind of need a bib because you're drooling. So I basically, I had a towel on me even on my flight home, I was drooling. I just couldn't still feel my lips because they were numb. So be prepared, have a bib for the flight if you're flying home. make sure that whoever's taking care of you is a loved one, so that they're tending to you and willing to get up in the middle of the night to get you fresh ice. Liquid antibiotics and liquid pain meds, like I was saying. And I flew home on the 5th day. I might suggest staying 7 days. So you're kind of getting, a little bit further into the recovery.
Oh, only 7 days. Dr. Gunson told me that 3 weeks would be necessary after surgery.
Yeah, everybody's different. So Dr. Alfie was my surgeon. I think he generally tells people a week. I don't like to listen because I'm not the best patient and I wanted to get back home. But yeah, I know he has people stay for 3 or 4 weeks after.
And sees them every single day during that multi-week period to check in. Dr. Bell does the same. I guess they actually want to physically examine the site for a couple of weeks daily.
Yeah, Dr. Alfie came to see me the same day, and I think I saw one of his associates the following day. And then I went in the morning I was flying back for a cone beam scan. And I don't know how much there is to really fully. Of course, you can look at the tissue, but there's really not a whole lot. You're looking at sutures, I guess. There's not.
Yeah, watching for infection.
Yeah.
And maybe with Dr. Alfie's more minimally invasive surgery, it being a shorter surgery and therefore less disturbing of the site, maybe that's a factor for less need for post-op care.
Very well. I think the more efficient you're in and out of surgery, the morbidities, everything is minimized, if you will. So
yeah.
So
you mentioned your boyfriend was taking care of you. What was that like to have like a partner where physical attraction is part of the calculus, and them seeing you in that state? How was that?
Well, there was no attraction at that minute. Sorry, everybody, you get to listen to everything. You're just like, you are in a level of misery, and you're just like, I actually had a breakdown in the shower. I would take showers multiple times. Actually, that really helped me. Just having the hot water, which is not the best thing for inflammation, but it helped calm me. So that's another thing. I don't remember which hotel I stayed at. The hotel I stayed at, whatever one it was, had quite a nice shower. I think it might have been a Westin. I'll find out. But
that's a great tip, though, to look at the shower at the hotel you stayed. No, seriously, hot showers are so soothing for me. Anytime I have a migraine, the hot shower is my savior.
I know. So this it was like one of the nice stand-up ones, not with a curtain. But I found I think I went in 3 or 4 times just to it helped with the drainage because you can't blow your nose. And it was mentally calming. And then I you look at yourself in the mirror and you're like, what did I just do to myself? And is it worth it? So I tried not to look in the mirror. So don't look in the mirror if you can help it.
Great tip. Wow.
However, when you're syringe feeding yourself, you kind of have to look in the mirror because I couldn't feel my face. So I had no idea where the syringe tip was. It was a little wild, but, so there's, you really can't think about a whole lot, whether it's your partner or I watched a lot of TV. That was actually something I never do. I watched Bridgerton and all those shows.
Downton Abbey?
Nothing Abbey. No. So yeah, I honestly, I wasn't even thinking about my kids, and they didn't want to, when they saw my face for the first time, they all turned pale, like the swelling. And they were, so that's something, if you have children, I would kind of, prepare them that mommy or daddy or I go by mama. I'm not going to look quite like myself when I come home.
How old are they?
I have 15, 12, and 9. And the 9-year-old is the one that was mostly a little terrified to look at me. But it's adorable now. They all tell me they love my new face. So that's
great.
But
thank God.
Oh, I know. So
Well, these are the things I think about too.
yeah,
I often wonder, like, if I were to do a jaw surgery in the next couple of years, how a much younger child would respond and whether they would be permanently sort of frightened of me
yeah,
for seeing me in that state. It's either that or you don't see them for 4 weeks, right?
yeah.
And that's not good either.
No, but honestly, I mean, I feel, so this is another crazy, don't do this. So don't go back to work at day 8 because you think you're superhuman. Like myself. I think you really should take the bare minimum that Dr. Alfie recommends is 2 weeks. And I don't know, well, I'm a workaholic, so, I can't sit and do nothing idly, but I would not go back to work for 2 weeks at least.
When did the scary stage end where?
That's where I was going. It was probably day 10-ish, maybe day 10 to 12 is where the swelling is just all down here. And I jokingly, I think I said it last time, at least the way I felt like I was like fat bastard meets Thanos. Just the way you're like, not as, but if you can imagine, it's that kind of, like all the swelling just kind of migrates down. So
you look like a wrestler with a big neck.
Yeah. And I wasn't black and blue terribly. I mean, you could see that yellowish color from the drainage. And I would advise not talking, also keeping talking to a minimum. It was really fatiguing. And you should talk, like we talk about after, like when we do a tongue tie surgery, you want to move the tongue. You want to get the function going, but a lot of talking is not a good idea. So some talking, but I would say just taking it easy. But yeah, by 2 weeks, I felt like the swelling was pretty much gone.
And do you think that was a function of the Dr. Alfie surgery being minimally invasive, or have you seen patients from other surgeons where it's more like 4 weeks instead of 2?
I have not seen as many patients because I don't see them till a bit later.
Right.
So I think I truly attribute it to Dr. Alfie because just like with any surgery, the quicker you're in and out, truly you have less pain, you have less swelling. So I'm going to give him a check mark on that one.
Yeah, no doubt. No doubt. What would you say, the emotional low point after surgery where you were like, did you feel any sense of dread or depression or feeling like this was never going to end? Or was that sort of counteracted maybe by airway improvements and excitement, or what was that all like?
Yeah, I think my low was when I was still there. And really just that first 3 days, 4 days, was really my low. And maybe, it's, like I said, looking in the mirror is like the worst thing you could do. And even though my boyfriend was there with me, my kids weren't with me. So, you're in this hotel room and it's a hotel room and it's hard to feel your face. And, so I think not my dread, but my low point, like I think I started to say, I had a few emotional breakdowns and I think it's good though to be just like, get it out and, it is what it is. And I made the choice and you can't go back. And, but I honestly, like by the time I was in much better spirits, all my, and it wasn't the worst, like terribly low. And I tend to be a more optimistic person. So, but by the time I went to my post-op and then we were on the plane home, I was feeling like myself, not literally, but I felt emotionally better.
Like that you had survived it and that life was going to go on and the worst of it was behind you.
Absolutely. And I'm just a doer and a go-getter so I'm just like, I'm on a mission. I got stuff to do. So,
yeah.
And not everybody's like that, truly. But maybe it's because I was recovering efficiently. I don't know that I was able to mentally get there, but I think like before surgery, I do a lot of surgery myself. I don't, as you know, I'm not a jaw surgeon, but I look at jaws. I mean, I look I have no issue with watching surgeries, but I never had watched I've never watched an MMA, and I didn't want to even look at anything beforehand going in. And it was like, I think for me, it was like, if I don't think about it, it's going to be better. And so I flew to Houston. We had a day where we went to NASA. What's the NASA thing over there? Houston, we have a problem. NASA, I think, had
the launch pad.
Yeah, we went there. So yeah, we did fun stuff the day before the surgery, and then went for a nice meal for my last meal. And then I couldn't eat my food because I was like, oh my God. Oh my God. I
nervous?
Yeah. Like it didn't hit me till like 7 p.m. And I had ordered the A5 Wagyu steak, like the really expensive steak.
Good for you.
But I could only eat like 3 bites. And then I was like, then it set in that I know. So that I fell asleep fine, and I was not the first surgery of the morning. So if you're going to do surgery, try to be the first patient of the day. I was the third, and I think my start time was 1 p.m. and I checked in at 10, and then you're just sitting there like waiting. And so I would say try to be the first patient. So you're just not having to think about it. But I think
it's another great tip, honestly.
Yeah.
Love that. I totally agree. It's just less time that you have to suffer mentally.
And stew. Yeah. And I maybe I'm unique because I'm so overcommitted in my personal and my just life. If you knew what was going on right now in this place, anyways, I'm rebranding. I'm new website coming. Everything's so I always have so
exciting
much
stuff.
Yeah. So much going on that I think that's what enabled me to not dwell on it before. And then it was really or maybe it was like subliminal. It was like not subliminal, but
there was sort of a positive current underneath the surface, but then you also sort of steered the ship with it, and you ran with it, and then you ended up going to better places.
Yeah. Just I think it's better not to think too much about it,
I think in general, like an idle mind is the devil's playground, and little things that get your mind out of itself are often the simple cures to depressive emotions or anxiety, like running errands or exercising. There's a reason exercise is so effective, is because it gets you out of your head and into your body.
Yep.
And I could see how sulking after a jaw surgery and thinking only about your jaw surgery after your jaw surgery could lead to an artificially negative experience or an unnecessarily negative mental experience that you have.
And maybe that, I mean, I just now putting it all together, I think, getting out of the hotel, getting home, and then I didn't do a whole lot of activity, but I was keeping my mind busier, if you will. I think if you sit in a hotel, it's kind of depressing.
Just even without jaw surgery, it's kind of depressing. Yeah.
I know.
I mean, what happens in hotel rooms? Not the best stuff.
No. And, you know what? Bring your own pillow. That's another one. Bring your own pillow. If you have a pillow that you love, because if you're, I was in bed most of the time. Hotel pillows are not that great.
Mm-hmm. No, they're nasty. And are you facing up on your back all night?
Yep.
No side sleeping, right?
No. Yeah. Your head elevated for the swelling, but also just like, you want everything draining down.
So if you could summarize the spiritual component of your recovery and sort of distill it down to a take-home piece of advice for the audience about spiritual advice for jaw surgery, what would it be?
Yeah, I'm not a very religious person, but I think practicing mindfulness, just having a plan on just literally like activities, like you're going on vacation, have things, but obviously nothing too exciting and too active, but have a plan. where you're interacting with humans and doing the things that bring you joy, I think would be very powerful. And I think it's hard if it's one of the surgeons that does like you to stay for a long time, that's going to be a little more challenging. But Dr. Alfie, he really wants you getting up and moving. And I didn't follow that. That was my own. I was exhausted. And I was not a good patient. I told you that. But the more movement, I think that would help, just to get circulation and get your mind free of the demons, if you will.
Sure. I think that's some fantastic advice. Thank you. And last question on the recovery side of things, and then maybe I think there's a few directions we can go. We could either go before surgery, what you were thinking, or we could go long-term recovery and outcomes. But did you consider any other recovery catalysts, like maybe hyperbaric oxygen or some of these other therapies that people are considering after jaw surgery?
Yeah, I hadn't heard that one, but it makes sense. It does make sense. I do think there's a few, and I actually have them here in office. There's a few different technologies, lasers, and infrared lights that help with healing. So a technique called photobiomodulation is using laser energy light to help with healing and nerve regeneration. And so that's something, the best of the best is the photona laser. So same laser that does night lays. And if you have heard of baby laser, we don't need to go down that road, but the photona lasers are the top of the line. So finding a provider that has that laser.
And you do that?
We do that.
You offer?
Yep.
Okay.
Yep. I have a whole crazy amount of technology to do really neat things. But so we have the photona, and then there are all sorts of red light therapies. You can buy cheap ones on Amazon at Nordstrom, but the really nice one is the Saluma, and you can buy it. You don't have to be a provider to buy it, but they come in all different shapes and sizes. But that also stimulates healing. So those are two.
So what would a protocol with either of those tools look like post jaw surgery?
Gosh, if you could do the Saluma every day, I mean, if you own it, you just can put it on. It's about 20 to 30 minutes. For photobiomodulation, there's no written protocols, but if you could go in twice a week for a number of weeks, I think that would be awesome. There's a provider here in the Seattle area that she's a hygienist, myofunctional therapist, esthetician, and massage therapist. Well, so she's a hygienist, but as she delved into myofunctional therapy and she had her own jaw surgery, what she found was that there was not a lot of options for facial recovery, if you will. So she developed some techniques to help with stretching when it was safe to touch the face, but different things to help with mobility and getting better range of motion after. So finding someone like her, and she does remote work, would be neat. She's kind of building her own little field, if you will. So, and I think nutrition.
And what's her name?
Sorry. I didn't mention. I'm sorry, Rebecca Clark.
Okay.
And she did offer a few classes and we went, but it wasn't enough time to learn what she's doing. So, and I think Renata Neem, you probably know, I had talked to her last fall at the World Dental Sleep Conference about that component. And she said she was working with her mentor in Brazil on being able to offer that. So we'll see what she's doing. I haven't talked to her in a little bit, but so I would say nutrition too, if you can, with supplementation, beyond, of course, eating healthy, but really trying to get better, getting your building blocks in for helping.
What supplements would you recommend?
Oh boy.
Just basic stuff like get your vitamin D, your magnesium.
Yep. Yeah.
Maybe some bone builder stuff.
Yep. Trace minerals. Yeah. I think actually it could be really neat to, well, I think front loading too, kind of like we were talking about. I think doing things pre-surgery, and then obviously when you can swallow ginormous horse pills, otherwise known as your omegas.
And on that note about pre-surgery bulking, when it comes to hyperbaric oxygen, I think that people are doing that mostly before surgery because you can't really do it directly after surgery because you're in a pressurized chamber.
Right.
So I have one client who actually got his own hyperbaric oxygen machine and is going to be doing it daily for 6 weeks before his surgery with Dr. Wallin. And then I think you need to take at least a couple of weeks off after.
Yeah.
So why don't we move on from the recovery subject? And I just want to go to before surgery very briefly. Mm-hmm. I want to ask you 2 questions. What was the moment where you were like, you know what, I'm going to do this. I'm going to do this jaw surgery. And then what was the moment where you felt comfortable with Dr. Alfie or with your surgeon of choice? Because those, I think, are the 2 big hangups for people. It's like, am I really going to do this? Mm-hmm. And I think a lot of people waver, or they go down the road of thinking about jaw surgery, maybe even doing a couple consultations. I'm among these types of patients. And then you get even deeper, and then you realize, you know what, I can't do this. It's just too scary.
Yeah.
And then I think another thing people get hung up on is indecision about their surgeon.
Yeah.
So they get it's sort of paradox of choice, and then they believe that there's a perfect answer out there in the ether somewhere, but of course there's not. No. There's a risk no matter who you choose. But talk to me about your experience with those 2 pre-surgical issues.
Yeah, I did not interview. I didn't go for consults everywhere. I was in a class. I've known Dr. Alfie for a couple of years, and I was at a class, which I've now taken 3 times because it's just you always learn something new. It's not the same old. But the first time I met him, so it was at Dr. Todd Shire's office. He's an amazing periodontist that works in Houston, actually, with Dr. Alfie quite a bit. And it's a perio ortho course. So MARPE, SFOT, and then jaw surgery has now been part of the lecture. So it was January of 2024. I was in the class. That was the second time. Sorry. I took it again this year. And then Dr. Alfie was showing all of his cases and explaining his average surgical time. And then I was just like, I was sold. Everything looked beautiful. The fact that efficiency, and I know when it's like I keep saying efficient, but the shorter the surgical time, the faster you'll recover. So I honestly I didn't go anywhere else. And I'm kind of that way. I decide I don't like having too many choices. I can't make a decision. So, and my insurance covered it. So
Blue Cross.
Mm-hmm.
Yeah.
So I only paid for my genioplasty. So
total out of pocket for you was sub 10K?
Yeah, I had special pricing for my genioplasty, but yes.
Okay.
But yeah, there was a fee, but I'm a very good negotiator. Like, anybody needs a car, bring me along.
Well, you're persistent. I'll give you that.
I try.
Not everyone ends up on the podcast twice.
Yeah, well, I'm fun though. Come on.
You are. No, I'm kidding. Yeah. It's my pleasure.
No. So for me, everybody's different. Like, if you want to, there's so many amazing surgeons, and I just felt very comfortable with David. And we actually grew up in the same town. It's kind of funny, but I didn't. I'm just
in LA.
Yeah, in the Valley. Both of us are Valley people, Valley girl, Valley boy. So I don't know. I just felt comfortable, and I just, for me, it's like, okay, I decided, I booked it. And then
were you aware of other surgeons were you aware of like the the battle of the surgeons, so to speak, that a lot of patients that get deep in the space go through?
I know who all the, like everybody you've mentioned. I've not really interacted quite a bit, but I know of Gunson and Reza Movahed and Larry Wolford and Dr. Bell and Stanley Liu and Casey Lee. So I know all of
the usual suspects.
Yes. And then Seattle, there are a few here, but I don't know. For me, it was like I need to go to one of the best.
Yeah, Dr. Bobek is another name that comes up a lot in Seattle.
Yes. When more recently, yeah. And I don't know. I've seen a few of his patients actually that are not doing well. So that's a whole nother, I don't know that it's a surgeon thing or that the patients weren't prepared going into the surgery, or there's more that should be done before surgery, which we haven't really talked about. But I think patients think magically, we were talking about this yesterday, like magically everything's going to just get better and everything, all your problems are going to get solved. And it's really not, that's just one part of the structural. I know we went off topic. I'm sorry. We love doing that. But so that's very much on topic. Yeah. Totally. But anyways, so for the people though that are not shopping, but I think just it is such a big decision. And I think it's always good to get a few opinions. And if you put 10 doctors in a room, we're all going to say something different about whatever it is, the diagnosis. Well, there's only one diagnosis. The solutions will all have different treatment plans, but I think you could just make yourself crazy in a way. And I think you just have to go with who you feel meshes most with your philosophy. Financially, I think everybody's probably very similar in cost. But I don't know. I think I don't know how you compare them. Yeah. But looking at the results is one thing. But I think what would be really interesting is to do like a retrospective and interview patients to see pre-surgery diagnostics, objective, subjective, and then come out a year later and revisit and see because I think that would be more telling than just the aesthetics.
Totally. I have often imagined a database where every surgeon got outcomes as expected, or a positive outcome score that was based solely on patient feedback and not on cherry-picked cases posted on websites or social media, because obviously surgeons have the ability to cherry-pick. And so there's an epistemological problem with choosing a surgeon based on what they tell you. And yet there's nothing that exists apart from maybe the jaw surgery subreddit and some Discord servers where patients at scale are reporting what their actual outcome with specific surgeons was like. But that information hasn't been consolidated anywhere into like a sheet or something.
It would probably be alarming, to be honest, I think, because I don't know what the follow-up protocol is for these surgeons. I know I'm the bad patient. So I think I was supposed to see Dr. Alfie at 3 months and 6 months. And I just waited till I think I waited till the 6th month. I can take my own CBCTs. And so I was able to more so do a virtual, but I don't know that the surgeons are aware of like really what sleep-wise, unless they're recommending doing a sleep study again or testing nasal resistance, which you can actually do. I don't know if you've heard of 4-phase rhinomanometer.
I have.
We got one. We're going to be implementing it soon, but I think that would be a nice objective test to see where we're at nasal function wise before, and then where we're at after. But I think we really should try to have objective, and there's subjective questionnaires as well, and interviewing patients. And is this what you expected, or what would you have done differently, or I don't know. I think that would be really amazing for patients to be able to know that information, not just how amazing you're going to look, but
Yeah. Let's take the nasal function tab that you just opened and put it on this display over here for a second. We're going to get back to that because that's a huge question, an open question in the JawHacks world, actually, is jaw surgery and its true effect on nasal breathing. But I want to double click first on this other question of vetting surgeons pre-surgery. You told me last night that you were not only were you not a surgery first candidate, but you were, as in surgery before orthodontics, you were a no orthodontics patient, meaning you had no orthodontics before or after surgery, which is unusual. I would assume then that you probably went into surgery with no TMJ dysfunction, a fine bite. But for patients that have pre-existing TMJ dysfunction, or certain malocclusions maybe that require extra care, do you think that those patients need to vet surgeons maybe based on the level of attention or the due diligence that they're going to pay to the bite? Because I think the bite is often not given as much love as it should when it comes to surgical planning.
Yeah. Well, I'm unique though. Of course I'm unique, but I always say I'm crazy, and somebody said, do not say that. Just say you're awesome. And I'm like, okay, yeah, I'm awesome. No. I had ortho as a child. I'm a I still am, 4 bicuspid extraction headgear case. And I did ortho again as an adult after I went to the Coyce Center, which is not airway so much. Well, they're trying to be airway, but I was like, oh my God, my occlusion. So I did have ortho when I was, I think, 28, 29. So I was pretty functional at that point. But then when I delved in, and tell me if I'm going in the wrong direction, but I think we talked about this last night. So then when I entered the airway world, I tried almost every modality prior to jaw surgery. So I tried I tried a DNA appliance. I couldn't even tolerate it in my mouth for more than 5 minutes. So it got thrown away.
Because it's just such a big, bulky piece of plastic?
Yeah. And I mean, people tolerate them. I could tolerate a night guard. I couldn't tolerate even a mandibular advancement appliance. So for me, I don't know if it was texture or too much stuff in them. I don't know what it was, but again, being a bad patient, I wasn't committed. I also wasn't committed because I wasn't paying for it. I think you're more committed if you're like,
have some skin in the game.
Exactly. And then I went into an AGA, and I was fine. My A point did move about 3 millimeters forward. Then I took my first MSE course, and I'm like, get this AGA out of my face. I want an MSE. And I didn't split, as we talked about. I just had cortical punctures, not piezo, and it was an MSE. I didn't have enough TADs. So at that point,
you had 4 TADs?
4 TADs. And
was it customized at all, or was it just an off-the-shelf block?
Yeah, off the shelf. And it was pre-partners, power screw, tiger screw days. So,
did you cortical puncture yourself?
No, I had my periodontist do it, and I had him place it too. My ex-husband, I didn't want him doing it's just not good to work on family members. So he cemented it for me. And then I think I might have had custom bands. I can't remember, but so I didn't split. And I just was like, well, again, when you're the patient and the doctor or a doctor, I wasn't on the mission like most of your clients are. So I really hadn't put a lot of thought into what my next steps were until I heard when I was at the lecture in January of last year. So my bite was pretty decent, even though I had.
So you never had any successful MARPE pre-surgery?
No, but I attribute it to when I did the MSE, that was pre-customization. So at that point, nobody was doing more than 4 TADs. Everybody was using the stock MSE. We didn't have, that was 2021.
Yeah, the only way to get more TADs was to do tandem MSE, to put two devices in.
Or Dr. Lipkin, he was soldering. He's hilarious. He's wonderful. He was soldering. He has a laser welder, so it wasn't soldering, but laser welding little lug nut things. So he understood the need for more. So he was making them himself, actually. So that was that. But
yeah, Dr. Lipkin, I think he discovered Partners Lab and created that out of thin air.
Yeah, fortunate. They're wonderful to work with.
Yeah, he doesn't own Partners Lab, but I think he found Jamil and then started telling Jamil, "This is what I want."
Yep.
And then everyone realized, "Hey, this is a better product. Let's all tell Jamil this is what we want." And then here we are, and now those designs have gotten extremely sophisticated and very customized, and competing with the FME, which is sort of more off the shelf, although it is very it's not off the shelf, but it's a standardized but also customized appliance that I think has some of the best design features. But Partners is always running toe to toe with FME.
That I haven't researched that one, and I know you asked me last time. I haven't researched that one enough, but
check out my videos on
it. Oh my gosh, my commute is only 5 minutes, so I don't have any time to listen to books on tape. I wish I actually.
Yeah, just it's worth knowing about because it even if it's just to give perspective on custom MARPE from Partners Lab.
Well, now we're doing. So I don't know if you've met Dr. Lena Sapoznikoff.
I've seen her around. Yeah. I haven't met her though. We've DM'd a little bit. I think I invited her on the podcast one time, and she seems great.
She's amazing. So there's our little posse of 6 of us. I think I've told you our little MARPE family is. We're all GPs, and but we're all kind of at the forefront. So Dr. Roca, if you've met Dr. Lupi Roca, Joel D'Souza, Shannon Thorstensen, and Jetta Holloway. But anyways, Dr. Lena studied with Dr. Heinz Winsauer out of Germany. And so she started doing this, and now I'm doing it as well, where we're placing TADs first. Then we make a suprastructure MARPE, and then you then tie it down with cover screws. So you can swap things in and out.
So a 2-piece construction.
Yep. So you can put 4, you can put 6, you can put 8 implants and then attach it. So that way you can swap. It's pretty neat. And they're a little bit wider diameter. And the TADs are much better threaded than what we all use for classic MARPEs. But anyways, total diversion. But
yeah. Thanks for sharing that. No, the FME is also a 2-part construction, and that's one of the big features.
Okay.
So
I need to. It's gonna go on my to-do list. Got it right here.
Sure, homework.
Yes.
So you never split before surgery, correct, but you tried some tooth-borne stuff, and therefore never really got nasal floor expansion.
Correct.
Went into surgery. Is this the direction you were going? Went into surgery hoping that would solve your nasal breathing problem? Why don't we go there, since we're sort of running out of time? Yeah. And I know that's a big thing we wanted to talk about. What was your thought process around your nasal breathing? What was your nasal breathing like before surgery? What were you hoping to get out of your MMA surgery with Dr. Alfie with regards to nasal breathing, since your MARPE failed? And where are you at with that now?
Yeah, I don't have an objective measure, but I know there was more resistance than there should be in an optimal face, or no.
Nasal resistance.
Nasal resistance, yes.
Mm-hmm.
I didn't have.
How did you know that? What was that like?
So you should be. Well, I think I had a little bit of stenosis. No, I can't remember because it was a long time ago. But stenosis, where when you inhale, these guys shouldn't really collapse. Yeah. So internal nasal valve collapse. But I could, and maybe it's because I live in the Pacific Northwest and we have a lot of, we have mold, and I never actually had any noticeable nasal inflammation until I moved to the Pacific Northwest. I grew up in LA. I went to college in Boston. I lived in Colorado skiing for a year, and I didn't notice any congestion until I moved here, interestingly. But so I knew there was some level of resistance. I just knew. And I went into surgery knowing that I literally had a cocktail straw-sized airway, knowing that would get more optimized. My profile would be more optimized. And Dr. Alfie talked about how he shaves the bone on the floor of the nose to help widen that opening.
Yeah, he cuts right along here and takes out this piece of bone that's at the base of the piriform rim.
Yep. So that was my hope, because I wasn't going to be doing a 3-piece. It was just a traditional Lafort or MMA. But for me, because I was missing bicuspids, there was no opportunity to widen. Well, I guess I could have, but 3-piece wasn't an option because my lower teeth are already vertical. They're already
You would have had to do some SFOT before surgery or some kind of lower jaw widening surgery to set you up for a 3-piece.
Correct. So ideally, if I could go back in time, we were talking about this last night, I would have done a MARPE and I would have done SFOT first and then the jaw surgery. So I don't feel like, maybe I have a little bit of an improvement, but I don't know. I know it could be better.
Percentage. Give me a percentage.
I think
15% improvement.
I feel like I might have improved like 25%. I don't know. And I still have, it's been a year. I have this, and I've heard this from other patients, this really weird thick congestion, like at the superior part of my nose. I don't know. It's
possibly related to jaw surgery.
It only started after. So
do you think that something got inflamed and then never settled down?
I honestly don't know. I don't know, but I don't have an answer.
Maybe related to maxillary nerves.
Yeah, but I mean, but there's schmutz that, there's stuff that comes out.
Oh, schmutz. Oh, there's actual snot.
Yeah, there's actual. Yeah.
Is it thick and like?
It's very thick. It's weird.
And it still comes out.
Yeah.
Is it? Yeah. Wow. And it's like of a color and of a consistency that's unusual.
No, I mean it's super thick, so that's the noticeable. Color wise, it's very not clear, but not infection, not white blood cells and yellow green. So, but just something interesting. And I have one patient who, it sounds even worse. She described it like I felt, but hers is like even more dramatic. So,
wow. Well, that's kind of alarming that a surgery, a jaw surgery, could actually, in a sense, worsen nasal breathing.
Yeah, I mean, I don't think it's worse. I think it's better. It's just that weird. It's a weird finding in a way, but it's gotten better. It's not consistent.
Did you have, maybe we should talk about the specific maxillary movement that you had, because I think that can make a difference on the nose too. Mm-hmm. Did you downgraft and therefore heighten the nasal airway, or did you impact at the front maybe as part of a rotation?
Yep, I had a counterclockwise rotation, forward movement, and I guess we did impact because I didn't realize I was that vertical. I didn't see myself as having vertical maxillary excess, like too much of a gummy smile. But David, sorry, I called Dr. Alfie David. He thought I was, and so my concern was that I wasn't going to show any gum. And when I smile, you can see just what you should see, but I was just worried based off of my education from the Coy Center, where my cuspids were, my canines were going to be. I was just worried. So, but everything's fine. Everything's fine. So,
yeah, your smile looks great.
Thank you.
Just right.
Yeah. The only thing that's weird is when I talk, you see a lot of lower teeth, but I'm still numb in my lower lip. So I think I might be compensating. And you see, I never used to show lower teeth when I talked.
Mm-hmm. Yeah, maybe once the lower lip comes back online and you get better control of it.
Yeah.
At what point do you think after surgery do you say, you know what, this is just it?
Well, I keep improving, like from the numbness perspective.
All things considered, but I guess numbness, sure. A year, 2 years?
I mean, what they told me was not to expect nerve recovery for at least 6 months, but more like 12. And the other thing, sorry, just popped into my mind, acupuncture is awesome to do after surgery. Sorry, add that to my list.
Mm-hmm. Sure.
Oh my God, I totally forgot what we were just talking about.
Yeah, we were talking about numbness of your lower.
Yes. Thank you. So I'm at just past 12 months, and I still feel changes like on a weekly basis. I mean, one would think by a year things are pretty set where they are, but the body can continue to heal. So
yeah. Are you considering a MARPE going forward? Have you thought about that? And if so, are you aware of the risks associated and the challenges associated with that? And how would you sum that up in a nutshell?
Because there are a lot of patients, like we were talking about, that had MMA, whether it's recently or a few years ago, and they're still feeling they're symptomatic. And
specifically with their nasal breathing.
Yep. So I'm not doing anything more. I'm tired.
I know the feeling.
I'm 40, turning 47, and I can't do anymore. Maybe if I retire and have nothing to do in my life, I might consider doing more. But for me, again, I'd have to do MARPE, and I'd have to do SFOT or something to widen my lower. So, so a lot of people are coming. I have not done it yet on a patient, but my colleagues have done expansion with the plates in. So that's a consideration, is the hardware, and then being able to expand. They're doing it successfully without removing the plates, but I feel like removing the plates would give you a better success and everything splitting symmetrically.
Well, you probably have a plate that crosses your midline, right?
I do. Yes.
So you probably would have to remove your plate, I would think.
Yeah,
right?
I would. Yep. It is crossing. It's funny. I'm like, I don't remember, but it's on the, I have my comb.
Oh, yeah. Do you want to take a look at that? And did you say that you were going to show us what your nasal aperture looks like pre and post surgery?
Yes. Here we go. Is that better? You got it?
Yeah, and I've told you last night, this is a question I'm seeing all the time now in my coaching is, hey, I went to do a jaw surgery. I got talked out of MARPE, even though nasal breathing was one of my primary complaints. They told me that the surgery would fix it, that MARPE was just going to make a mess of things. It was going to add time and cost and complicate the orthodontics, and that I should just trust the MMA. And they do the MMA, and they have this whole new sort of lower third. It's their tongue base is great. Mm-hmm. But their nasal breathing is right where it was before surgery.
Yep.
And that's a tough place to be.
It is.
Because MARPE is way easier to do before surgery, or even if it's a matter of just planning in a segmental effort by doing SFOT on the lower before surgery. It's just one of those things that has to be carefully sequenced.
I am a huge proponent of MARPE first, always. And we were talking about that. I think a surgeon would say otherwise, which is why I think patients are getting talked out of it. But it's the most stable way to develop the maxilla, because it's going to be solid. Where when you're doing it with a 3-piece, let's say you set it, wherever you set it, you're going to lose some of the bone. So if you really need a centimeter of transverse development, you're going to get a centimeter with the MARPE. and you hold your, we leave the MARPE in for a good 6 to 8 months, depending. So that bone is not going anywhere. And I truly think it should be an always as the first step.
And do you say that applies to patients that specifically present with distinctly poor nasal breathing?
Absolutely. But the other thing to consider is the nasal breathing, is it anatomical or is it inflammatory, right? Because we can have inflamed nasal passages from like the environment, like I was just describing moving to Washington, and then all of a sudden I have inflammation in my nasal passages. Or is it really tiny? Like if you look at my nose here, this is an almond. That's my nose, right?
Yes, you're not sharing yet.
Oh, I'm not?
No, please do though.
Uh-oh, hold on.
Please
everybody.
do.
I hit share. Okay, let's try again. Sorry.
It's okay.
Okay, let's try again. Yay!
There it is.
Sorry, everybody.
Yeah.
Huh.
Perfect.
Okay.
Perfect.
So this is pre-surgery, post-surgery. That's my nose ring. So when we look at the nose, you can see this is an almond shape. And then when you look at the skull, and I don't know if mine's in focus because I can't see myself, but we should really have a wider base. So it should look more like a pear or a triangle. I think if we look at skulls from, pre-industrial, that's the shape that we should have. So if you look at me, I am super almond right here, and I'm still almondish here. And when I look at, I don't have anybody else up, so I don't want to violate HIPAA, but when I look at my post-MARPE noses, they're shaped much more like a triangle. So you can really see the widened base. And I haven't seen any 3-piece before and after CBCT, so I don't know what it would look like. But if we can optimize the nose first, it makes, and I have talked about this with Dr. Alfie, a 3-piece is a much more complicated surgery. So
pre and during surgery, yep. It's more complicated.
So why would you not do a MARPE? Like, it makes no sense.
Oh, My point was that, it complicates pre-surgical orthodontics. It adds time. It brings in SFOT. But your point was more a multi-piece maxilla surgery is just more cutting, more plating, more that can go wrong at the scariest, highest risk point of treatment, correct, which is also a great point.
Correct. Because truly, if you do the MARPE and transverse is taken care of, all you're doing is correcting, AP and vertical. You're eliminating the minimizing the complications. So.
Yeah, and it should be said that MARPE obviously brings its own risks and complications around asymmetry and around often being unesthetic. For people that don't have an arch length deficiency, sometimes they end up with too much bone for not enough teeth, or like a more square looking arch, mm-hmm. which it's like a kind of a white wall when they smile, which is also not great. But these are the, that can be mitigated by just not overexpanding, or finding that balance between nasal breathing improvement and aesthetic sort of backtracking. Mm-hmm. Mm-hmm. But I think with MARPE technology now, it's a lot easier to get a symmetric expansion. And there's more information now for sort of self-advocating to make sure you don't get overexpanded or overexpanded into an asymmetry. That's another huge thing that I do in my coaching is I monitor expansions with people, because the orthodontists just don't always have time to meet with someone once a week, step back, zoom out, mm-hmm. look at their face, offer an opinion as to how they're looking mm-hmm. overall, not just how things are looking in the black hole. Yep. I do a lot of that, and I try to help people find that sweet spot, and it tends to be less. I don't see a lot of 1 centimeter expansions that I love, truthfully. I mean,
the only times when I've done a centimeter, it's if we're starting like with 28 or 29 millimeters. I mean, yeah. And how I treat implant a MARPE is all based off the lower arch. So I'm looking at, I put it all, I do it all in the software. So I upright the lower arch. I think I might have shared this with you last time.
Yes, you did.
And then I match the width of the maxilla to the mandible. But in a case like my own personal case, I was already as wide as I could be on the bottom. So that's when my treatment planning takes me into SFOT. And so in the beginning, I overexpanded. I didn't have the savvy, and I don't think that was in any of our education as to that level of planning. And now it's like a no-brainer. I know. To the millimeter, I'm pretty darn close. So, or not even millimeter, less fractions of millimeters. So,
so based on everything you've learned from your own jaw surgery, how has that influenced your work as a clinician and as an airway, a dentist who does lots of airway orthodontic type stuff and probably meets with lots of people who want a jaw surgery? How has it shaped how you do things?
So people are finding me for consults, not as much as you, but as to what do I do first. And I'm very candid about correcting cranial asymmetries first. And I know I don't want to go, we don't have that much time, but I like to do things in a very strategic order, getting posture and gaining as much symmetry of the cranium first before going into surgery. And then explaining, like, okay, let's first calm the TMJs if we have symptom. Oh, we never finished talking about the bite and joints. Sorry. But if we're symptomatic in the joints, getting those calmed down. If that's not an issue, then I look at posture and I work with specialized chiropractors that help me with that part. And I do orthotics as well to help the cranium get leveled, but that's another story.
Do you do orthotics to help you as part of a teamwork with a surgeon and maybe even a restorative dentist to find the ideal position of the joint, and then you build orthodontics, MARPE, surgery around restorative dentistry, around what the orthotic tells you?
So ideally, we should be doing that. Yes. So it's interesting. We're guessing where the mandible wants to be. And so if you don't deprogram or don't use an orthotic on some level, we're guessing where to put the maxilla, right? And once you do the surgery, it's set where it's at. So what I see is when I get patients, they're getting treated from my chiropractor. He takes the bite registration for me. And when that comes back, I build the orthotic to a very specific height and angulation that allows them. It's basically letting the mandible, I call it free it up. And then it lets the fossa and the joint remodel. So it's getting the just like when patients end up in an end-to-end occlusion after a mandibular advancement appliance being worn for so long. This is letting us get that mandible where it wants to be, physiologically, orthopedically stable.
And are you generally bringing them forward and letting them remodel into the forward position, or are you finding yourself setting patients back into a centric relation?
Centric poop. No, sorry. Everybody forgive me for, yeah. No.
Please explain.
Well, yeah. Often the maxilla is trapping the mandible. Mm-hmm. So if we're just guessing where the maxilla should be, of course, the more forward the maxilla, the mandible has more room to come forward. The orthotic that I make, it's not directing the mandible specifically to go to a certain position. It's a flat plane, but it's built at a specific angulation and thickness let me take a step back. So when I'm treatment planning a case, I'm looking at if we have a vertical discrepancy on the cranium. I'm trying to...
And you're talking in asymmetry.
Correct. So if we... so think of what we're not paying attention to in airway world and jaw surgery world is the cranium. So we have we're focusing right here, but we have all of this, especially the cranial base and the upper cervical vertebrae. They're all connected.
Can you lift your model up a little higher? It's just out of frame.
Yep.
Yeah, that's
Sorry.
okay.
So the cranial base, what I'm talking about is the occiput, the sphenoid, and then the temporal bones, those 4. And so this is like a half day, full day lecture, multi-day lecture. But if we don't pay attention to this and the upper vertebrae, we're limiting, like we can move this and cut it and do that all day long. But patients, I think, still have problems because we've never addressed the back here part and the below here part. And so why that even becomes an issue, it goes back to birth and gestation and how we're actually sitting in the womb and the birth process. Again, another lecture, another day. But
you're saying these are the things that shape our cranium.
Yeah. So yeah, I mean, we're squishy, right, when we're born. That's why we can fit through the canal. But depending on actually mom's posture and mom's hips, the baby can be wedged, the developing fetus can be wedged a certain way inside the womb. And then when they come out, if we're born, is it okay we're going in this direction for talking?
Yeah,
okay.
Yeah, absolutely.
So depending on how we're born, whether it's early, so before 39 weeks, late, which I would call 41 and later, vaginal versus C-section, is it induced Pitocin, what else? Vacuum, forceps, anything that's unnatural, if you will, it's going to affect the baby's function. And so it's also going to affect the cranial bones. So in a perfect world, babies would be born and they would see an osteopath or somebody that's going to help get that body realigned, if you will. But what I see a lot of when I'm examining my cone beams and when I'm looking at faces, I see a lot of distortion in the temporal bones, which the temporal bone is what makes up half the joint. And so I see a lot of asymmetries in a vertical manner. So then you'll see that the mandible shifted to one side and an anterior posterior rotation as well. But it's all from the cranial base. So we still can change that in a human by first, we can change it mechanically, which is what these chiropractors help me with. And then there's a part that I do in the mouth, and we can actually help get those bones more level. I think that's contributing to a lot of the asymmetrical splits is we're starting with asymmetry that nobody's really looking at first.
So you're saying that the maxilla and the mandible are like branches that extend off of a trunk, and the trunk is the cranial base, and addressing the trunk and making sure that's straight is kind of like a step one.
At 100%. And I know I'm like one of the only people speaking about this, but I'm seeing a lot of patients that are post-jaw surgery, and it's a hot mess. I mean, like everything's asymmetric back here, and they're still in pain. And they're coming with pain, not breathing. So there's multiple things that are bringing patients in, but I think it's a hugely overlooked and not talked. I mean, airways just barely percolating into education. I mean, dental school wise, I don't know what they're doing actually, but
well, Dr. Santiago, we have to wrap now. Unfortunately, I feel like there's at least another hour of stuff I'd like to go over with you.
Maybe I'll be your third time guest.
Yes, number 3, certainly, where maybe we can pick up on this concept of maybe you can show, because I think a lot of people would say, is it really possible to change the cranial base in an adult? That's ceramic. It's not clay. How would that even be done? I think you said you had some images that demonstrate that it is in fact possible. Maybe that's something we can check out next time.
Absolutely.
For now, where can people find you or become your patient?
Yeah, I do virtual consults. So I'm up in the Seattle area. So I have patients that fly in now for treatment, which is wild. I feel honored to be that special, or recognized. But I think it's great before you just start traveling. I can do almost a full workup virtually. So I do virtual consults. It's best if I have a CBCT and photos, but I can't do the full functional, like a tongue tie and soft I can do some of the soft tissue assessment. But I can do almost a whole workup with a cone beam and orthodontic photos. So, but yeah, my website is airsyncwellness.com. And yeah, you can request an appointment right through the website, and you get me for a whole hour with the virtual consult. So I prep before for about 20 to 30 minutes and slice and do all my diagnostics. And I'm happy to be a second opinion or a third opinion, or like I'm removed from the whole situation opinion. So I can give you as unbiased of an opinion as possible.
Fantastic. And I think that we'll see you next inside of The Joint,
yes.
My membership community, where people could meet you and ask you some quick questions, just as being a member of that. So check that out as well. Okay.
Sounds good.
All right, Dr. Santiago, thank you so much. And we'll be seeing you soon inside The Joint.
Okay. Take care, Ron.
Okay. Take care. Bye-bye.